Afternoon, everyone, and welcome to today's CMAI's Doctor Section webinar on healthcare resilience, risk assessment strategies for disaster-ready hospitals. So I am Dr. Vijit Sangma. I'm the secretary for the Doctor Section of CMAI, and I'll be the moderator for today's session. So this webinar is part of our ongoing series on disaster management. So today is the first one, and we'll have different aspects of disaster preparedness and response in the future. So, and this is designed to equip healthcare professionals and institutions with essential knowledge and practical tools to enhance preparedness and response capabilities. So before we begin, just a couple of housekeeping notes. So all the attendees, I know you won't be able to unmute yourself for now. So that is to facilitate smooth presentation by the presenters. And after that, we'll have the open forum where each one of you will be able to unmute and speak and ask questions. And if you have any questions, you can please submit them in the chat box. And we will be addressing the questions after the presentation during the panel discussion. And the session is being recorded and it will be made available in YouTube. And also the recording link will be sent to each one of you, those who have registered, and we have the email IDs. And the session will run for 90 minutes and we'll hear from 4 distinguished experts in disaster management and healthcare resilience. And it will be followed by a panel discussion. To start the meeting, I would request Dr. Rajiv Joy Nathan, who is the chairperson of the doctor section, to start it with a word of prayer.
Let us pray. Dear Heavenly Father, we praise you and thank you for this time that you've given us. Dear Lord, as we've gathered here, as we face tremendous challenges in healthcare, especially the hospitals and the buildings which we have, some of them are very old. Dear Lord, be with us as we meditate and we think about what we can do to help and strengthen the hospitals, to prepare ourselves for the mishaps and disasters that can take place. And I pray that you bless the speakers as they speak, guide them. I also pray for people who've joined and who are joining, so that the wealth of knowledge that is there, that is shared, is used for the betterment of the hospitals in the network. And as we prepare ourselves for the coming years, let us all be equipped so that the hospitals can run smoothly and we are able to do a God's work in the area that we are defined for. We ask this small prayer in the name of our Lord and Savior Jesus Christ. Amen.
Rajiv, for opening the session with a word of prayer. So since we have 4 presenters, what I'll do is I will introduce all the speakers at once, and then slowly as they move into their presentations, so that we don't disturb the schedule in between. So let's begin with the introduction of our speakers. So we have, can I request all the speakers to switch on their cameras? Yeah. So to begin with, I have Mr. Peniel Malakar, who's a health and humanitarian consultant and founder of Kriti, which is based in Bangalore. He brings extensive experience in developing risk assessment frameworks and also a lot of training and development of training modules for training healthcare organizations, and also responded to various disasters in the past, and we have had the privilege of working with him and also responding to different disasters and training in the South Asia region as well. Next, we have Dr. Neeraj. Let me just add to, yeah. So Dr. Neeraj George Paul is Assistant Professor and Emergency Department and Quality Manager at CMC Vellore. So Dr. Paul specializes in emergency preparedness and has implemented several innovative protocols in ensuring service continuity during crisis. Third speaker is Dr. Pritesh Kiran, an Associate Professor of Community Medicine and convener of the Disaster Management Unit at St. John's National Academy of Health Sciences in Bangalore. Dr. Kiran also has responded to various disasters and and also has been part of various development of training modules and training a lot of institutions. So welcome, Dr. Pritesh. And also we have, speaker is Mr. David Duncan, is a founder of Redify. They're based in Qatar and in the US. Mr. Duncan is an emergency management professional and who has advised healthcare facilities in over 15 countries on risk management strategies. So with all this, these are the 4 speakers that you see in your screen. And with all this, request Mr. Peniel to start. Let me the presentation for today.
To thank CMAI for giving this platform, and especially Dr. Section, Dr. Avijit and his team. How to go ahead? Okay, fine, it's working. Yeah, I'll be very simply taking all of us through the need for hospital resilience. That is, identifying risks is essential elements of hospital resilience. The topic for me is critical need for assessing disaster risks with its growing impact on hospitals. And we all know that this is genuinely a growing impact in the hospitals, because no place on earth is safe, right? And know your risks before they hit you. Very important. This is in Kerala, 2018, unexpected. Again, this is in Kerala, in Believers Medical College and Hospital. This is in one of the hospitals in UP. This is a neonatal ICU ward. Chennai, 2015. They felt the hospital is not at all this safe, therefore they're taking the patients away from the hospital. How many of us are careful about managing people with disabilities from the entry point till the patient moves out, who is affected by some kind of disabilities? That's a risk for them when they're not prepared. And of course, doctors, and this is in AIIMS, why doctors have to wear helmets? I think this age, it's no more doctors as a God is a God. It's ultimately when people are upset, they do not care anybody. So why undertake risk assessments in hospitals? All kinds of risks that you could see. I worked in a hospital at a beautiful hillock, Alipur, Bharat Christian Hospital. And I never thought that a storm will throw 2 very large trees and block the entire access and entry and exit route. We never thought that the flood around the hill will stop complete movement of patients. So disasters do not discriminate. Failing to prepare is preparing to fail, right? A very common and very old saying. And we can stop disasters from happening or impacting the hospital, but we can build resilience by reducing the risks. So therefore, again, identification of risks is extremely essential. This is the recent incidents. We all know about what had happened in Los Angeles, the posh, richest areas in the world. And they're affected like this. The hospitals were affected. The families were affected. We all know. Just listen to this few minutes video, how doctors and nurses and other staff had to leave this town, this city, because of the risks attached to
Thousands of
them.
homes and businesses have been destroyed in the Palisades fire. Many of those victims are local medical professionals. Now some fear that a group of these doctors and nurses will leave Los Angeles for other states. We're joined live by Dr. Jason Rustayan. He's a plastic surgeon at UCLA. He did lose your home. I'm so sorry.
Yeah, thank you
Yeah.
for saying that.
But 150 medical professionals at UCLA that we know of have been impacted by this. And I was told you do have a real fear that people could end up leaving the area or even the state.
Yeah, I mean, I think it's something we have to be conscious about. You know, as medical professionals, it's you got to stay close to the hospital. You can't just pick up and leave. We can't work remotely. We have to take care of patients. And I think it's just something to be mindful of, that, you know, making sure we have housing for not just the doctors, the nurses, the staff. I mean, it's a whole team effort. And, you know, it's too early to tell now, but I think it's something, if we're not thinking about it now, again, you know, when disaster strikes, you want to be prepared. And I think this is an important thing to be prepared.
So you said it all. And a few more pictures. This was just launched in the same year, 2014, in Jammu and Kashmir. They never expected floods to come in Jammu and Kashmir, and that affected. That is, and we all know about the fire incidents that actually provoked the government of India to work on hospital safety. This is in Nepal. And just look at the number of nurses to take care of so many patients. And then here, what you see is there are army people or some kind of para-army troopers, but they're not equipped well. So they are trained, but there is no equipment. So what is the use? They're using some traditional techniques too. So your hospital is trained for your respective purposes, but if you're not trained for emergency situation, then it will end up this way. Human contribution to disasters, right? And the richest community in the world is not spared. So the nature is responding to abusive human actions. So why should we do a risk assessment? There is a growing frequency of disasters across the world with increasing threats to all. And we all know that 2019 pandemic exposed there's a huge gap for preparedness of hospitals. Avoiding waste, like after the COVID, I visited at least 30 hospitals, and everyone proudly shows about see the stock of oxygen concentrators we have. Some of the hospitals they have, huge oxygen, center, liquid oxygen supplies, and many other equipment which was not used because it was not prepared and provided in time. So various data proves that there's an increasing trend of multiplicity of events. It's say for rain, heavy storm, rain, there's flood, and then there's an outbreak of diseases, and then you have floods lead to mass displacement. Therefore, a lot of things related to issues related to the flood and displacement. It leads to huge public health challenges. Studies show that disasters widely impact a country's socio-economic health. Again, there are many large world bodies, they have found this, and there are a lot of research you can read yourself. Hospitals are a temple of hope for the disaster victims. If something happens to you, what do? You rush to the hospital. If hospital is also not affected and not prepared, they themselves are affected by the disasters, how are you going to? Hospitals are high capital intensive organization. You can think about today and you can think about 20 years before, how many equipments are added. And Dr. Rajiv said about many of the old mission hospitals have got dilapidated and they have been adding one after another. And these are not safe for structures. It leads to huge risk. Hospitals are not immune to the impact of disasters, very obviously. In absence of strategies for risk reduction brings disruptions that are preventable. Obviously, therefore, there's a need for identifying risks, assessing risks, prioritizing, and then work on preventing. Cost of recovery is costlier than the cost of prevention. So how many of us take preventive measures? I'm sure all of us have done a life insurance or health insurance. Why do we do that? In the whole life, maybe we will not be needing this, but still we do that. So also institutions, especially healthcare institutions, should have the plan of risks or even managing risks by identifying. So stitch in time saves 9. No place on earth is free from any types of disasters, right? Hence, there is a need to develop strategies to reduce risks. It is essential for a healthcare organization to undertake a comprehensive risk analysis process or assessment process to identify more specifically the existing and potential risks. Internal and external risks from outside. Hospital is not directly affected by, but the location is affected. Say, communal conflict, riots, predictable and unpredictable risks. Okay. Prioritize the departments or sections. Today, Dr. Neeraj will be speaking about those medical emergency units of a hospital which need to be prioritized to work on preventive actions. Prioritize risks for taking appropriate mitigation measures, especially when you talk about mitigations, the structural and non-structural issues. So there should be a comprehensive risk analysis process. Okay, risk assessment is the first and most critical steps. Many hospitals I have found like, okay, there are some people, experts come there and 3 days workshop and happy. There's no risk assessment done, but okay, they're well trained. Trained for what? Have you identified the risks? One size doesn't fit for all. So another big hospital in California has various steps of preparing. It doesn't fit into a rural hospital in Northeast. So risk assessment, identification, analysis is extremely important. Diagnostic apparatus in the hands of disaster managers. There are various tools. One of the last topics is going to be very interesting, and Dr. David Duncan will be sharing about what are the available tools and what he has also developed, which I really felt extremely interesting. It will help you at a glance the level of risks of the hospital or the hospital that undergoes the risk assessment. Comprehensive assessments can lead to quality results, not just like some kind of risk identification. You have to go into hazards. What are the existing hazards? What are the vulnerabilities? Hospital with ophthalmology department, and hospital with orthopedic departments, or hospitals with any kind of department which is very vulnerable. And also talk about the capacity. Do we have capacity to mitigate them, respond to them, and how do we save people's lives from specific hazards? Undertake suitable measures to mitigate existing and potential risks and threats. So structural, as Dr. Rajiv also mentioned, like most of our hospitals are structurally very old, and we keep adding because new units, new departments coming. And non-structural mitigation, there are many costly equipments and tools which need to be anchored. Functional preparedness as well as response. We will not talk now at this point, but we'll talk about in the next series of webinar. So risk assessment helps to enable continuity of essential services, operations by safety and protection of staff, patients and visitors, and also the structure, ensure efficient and effective medical emergency response, gives organizational stability, faster recovery, because you have a plan at your hand, bounce back to normal quickly and adopt new situation easily. That will help the hospital recover easily, quickly, and to be into a normal phase. Ultimately, aiming to minimize adverse events, risk assessment can do that and deliver the first safest possible healthcare services. Implement preventive measures. So when you do an analysis, risk analysis, where are you and what is your target? Obviously, all of us would like to make sure that priority departments are brought their risk level to low. Risk assessment to help identify the potential risk to reduce the occurrence of spread of preventable accidents in hospitals. Something happened 20 years back, 5 years back, 2 years back, I've forgotten. There's no preparedness. There's no trying to understand what is the root cause and treat it. Huge resources of funds related to the health of society. So that is not just like financial, it's a human, physical, and equipment capital. So therefore, there's need for prevention or mitigation of risks, provides an opportunity to engage with patients and their carers and families in order to promote patient safety. We have found some hospitals, their patient in the middle of the night, they found out there's a spark and fire, and they helped. The recent fire incidents in UP, no, sorry, it's in Rajasthan. Patient relative actually took care of many, but there was an incident there. Some baby was misplaced. Somebody took away. But then it is important to let them also know what preparedness, where is the exit route, what are the equipments you have where. Because some patients' relatives also may be well trained. So, how to go about the tools and techniques? The Hospital Safety Index, WHO, SPAHO, they have found it out. They have developed one safety index formats. It's huge and quite not matching to our needs, but that is there. R2R, that RATS, Rapid Assessment Test, is what I have developed, organically finding out various methods to identify our situation where, rural situation, rural context, not very big hospital. No, we cannot take hospital safety index for a small 35-bedded hospital in rural areas. And I'm sure our friend David Duncan would share from what he mentioned, what he developed, the Redify 365 risk management software. Thank you, and I
opinion for keeping the time firstly, and also setting the tone for the discussion, and also talking about the risk assessment frame fundamentals that you spoke about. I think it'll provide an excellent foundation for our discussion as we move ahead. And now let's move on to our next speaker. Yes, request Neeraj will address strategies for ensuring continuity of emergency services during disaster. Over to you, Neeraj.
Thank you so much, CMI, for giving this opportunity to speak. So I am going to talk about some of the importance of undertaking risk assessment measures for smooth functioning of the medical emergency units. So, I mean, we should have seen all these, some of these pictures in the previous presentation. So this is the Gorakhpur tragedy when there was a shortage of supply of oxygen to the wards, and then many of the children passed away in the neonatal ICU. This again was seen, and everyone knows about the Zamri incident where the fire broke out in the basement of the hospital, and they realized that I think they had been given some few days, 90 days to cope up on the fire safety strategies, but the hospital did not respond. And 3 days after this deadline was crossed, there was a fire. And again, it took time to recognize that the fire had broken out, and it was almost 2-hour delay before the teams were alerted. So we lost around a lot, I think around more than 100 patients, and this is covered even by the New York Times. Again, this was in Maharashtra during the COVID time, an ICU blast. There was a fire, and many of the patients had passed away with that. Yeah. And then there is this in Assam when there was a flood, and a lot of interested staff and doctors had moved on to the streets with the patients. This was probably their backup plan, which is excellent. But then I don't know. I mean, could they have been done better than this? Could they have assessed the risk before and acted on it before? Was the question. And as we all know, during COVID, what happened? We were not at all prepared. Our major risk was we were not ready if there was no oxygen in the hospital. We never expected such a disaster to cover up or engulf the whole community where patients had no oxygen. And there was a time when we had to decide whom can we give a lot of oxygen, and there was we should not give more than this much oxygen for few patients. it was a very difficult time, and I think we all have gone through the same. So yeah, so what is common in all of these, as we all saw, it's the major part of the disaster cycle, the preparedness. So in preparedness, I'm going to talk about more of the importance of risk assessment in the medical emergency units, which is the most mostly in the ICUs, the emergency departments, and the dialysis units, and some of the understanding some of the aspects of risk identification and evaluation. So what exactly is risk assessment? Risk assessment is a process to identify, evaluate, and prioritize risks to minimize potential harm in an emergency setting. So mainly, it has two components: risk identification, finding out what all are the risk elements, and how to evaluate what is the probability and impact of the risk that can occur. So the role of risk assessment in emergency units. Let's look at it this way. So I will probably prefer talking an example. So we have a lot of, for example, we have a lot of patients coming in at one point of time to the emergency because of probably some disaster. And what happens exactly when that happens? When such a thing is on, we have a lot of shortage in the staff. So when there's a lot of care to be given, the staff performance naturally comes down. And there are some things that we may miss on treating patients. I mean, some patients might become sicker, and we may miss on that. So those are, and there's always a problem with resource allocation. It's like in COVID, who should get what. And after COVID, again, as Dr. Piniel said, a lot of cylinders lying unused because it's not required at that point of time. But all this eventually affects emergency care quality, and if you manage it well, it helps reduce in the adverse outcomes. So in the emergency scenarios, the types of risks that we are mainly concentrating on is clinical or patient safety risks. Here, medication errors, misdiagnoses, and failure to escalate care when required is mainly covered. Well, operation risk will be because there's a lot of patients or a lot of overcrowding in the ED, difficulty to move around, staff shortage, or inadequately trained staff being called from other wards because we needed help, or certain equipment malfunction or unavailability, with the shortage of ventilators when we need a lot of them in the ICUs or in the emergencies. Human factors risk, which is a major component when there's a lot of inadequate communication. We face this a lot in our scenarios when we have a lot of patients who come in and we need to involve some of the departments. When we call them on the phone, we might not be able to give them the entire sweet talk that they might want to hear on the phone. So, hi, sir, can you please do this, that? May not be, and they may not be happy to hear that either. You'll have to say probably sternly, doctor, so here, so please come and see the patient. May not be happy. So again, communication is a big problem there. Fatigue related errors. We are all prone to making all those things, and none of us are perfect. We all have mistakes. And naturally, it's all physiological mechanism. We'll have cognitive overload and burnout happening. Infrastructure-based hazards. These are again few of the risk elements. That is not few. These are the ones which is mainly causing fire and things like that. So slips, equipment malfunction, fires, and infection control is another thing that we don't. As there's a lot of shortage on our side in probably our country, I would say. So how do you understand or identify these kind of risks? So there are multiple ways of doing it. So this is one of the ways that we can do it is in incident reporting. So this is one of the form that we use for reporting our incidents. If something goes wrong due to some mistake that we probably would have done with unknowingly, reporting such an incident and developing that culture of reporting incidents and in a fearless environment, I would say, because they should not feel that scared. Oh, I reported this, I'll be caught, and I'll be in trouble. So developing that culture of openly coming forward reporting, and then talking about it and changing it so that next time the same thing doesn't happen. So, and staff feedbacks is a very good way of identifying the risk of fatigue and cognitive imbalance later on because of busy schedules and busy work. This can be done at the end of the shifts or something similar to that. Simulation based drills for picking up risk. So risk elements, many of the risk elements are picked up during simulations that this is something that could go wrong. And we could have found it out if we had, the situation had happened earlier. So this is something that we can do only if we, keep drills or do that again and again. Again, some patient outcome tracking, clinical audits is another way. This is the way we analyze it in CMC. So this is the picture is just an example. I haven't put the real one which we do it in here. So on the left side, you can see probability or the likelihood of what is the likelihood the risk will happen. So everything may not happen. You might have an overloaded or a plug point that is there in the ICU, which is probably might spark. You have two high wattage equipment connected to it. So there's a probability that might spark and fire. So maybe you put it as likely. Maybe 4, and then the impact, which is on the top, you can see how severe the outcome would be if the risk occurred. So if there is a fire, how severe it would be in an ICU scenario. In an ICU, is going to be very severe. So maybe put it at 5. So the multiplication of 5 and 4 become 20. So it comes in the red zone. So it comes as on the right side, you can see if it's red, it's most critical need of monitoring. So such things could be monitored more efficiently, and we can maintain a risk register. This is a template where you can document the risk you're likely to face, and the likelihood score, impact score, total risk score can be calculated. And based on this, you can plan your monitoring strategies or your dealing with strategy, which we'll be covering in later workshops, as Dr. Peniel said. So let's go into some of these challenges that we have discussed earlier. In the scenario of common clinical challenges, we can face high patient volume and resource constraints, leading to errors, delays in care, and increased stress on medical staff. Another challenge is lack of staff trained in emergency risk management protocols. Communication barriers, as I mentioned, the difficulty in prioritizing risk, which risk comes first, which situation has to be dealt with first when in such a scenario has to be talked about. I mean, these all impact your eventual outcome. So how do you identify this kind of thing? So there's real-time monitoring of patients. So even a patient who is going to the scan room or to get a scan or an X-ray and he collapses there, that is again a risk element that you missed. You could have prevented if I had followed up how he is going. Is he going with someone? So even small things like that is important. So one way we can do is real-time monitoring of the patient load, of how many patients are there in your department right now. Can be doing it in terms of using a software or a TV on display where this patient going to this ward in green, going to CT room and come back from CT room. So you can keep a track of where the patient is, how is he probably. And developing triage systems in place, which will actually help you prioritize which patient should go first. Environmental risks, which I said as lack of physical space because of overcrowding, broken, damaged infrastructure, plumbing problems, electricity, sparks, all those things related to that, and limited facilities to maintain infection control. How do you identify these things? You can have a pre-disaster environment safety audits. You can do that in your system. And rapid assessment of areas where you can identify in hospital when there's a surge of patients, where to place them. Operational risk again would be limited ventilators or limited medicines when you have a scenario when you have to have a lot more in your department. You don't have a plan earlier itself how to deal with it. So again, this is a risk element that you are supposed to be aware of, and such a situation can arise anywhere, anytime. Working one of the tertiary care centers, most of our ICUs and EDs we have almost a 90 to 95 to even 100% bed occupancy almost all the time. So we are at risk of a disaster at any point of time. So what my teachers taught me was when you have your when your needs always exceed your resources, it's a disaster, whatever it is, whatever scenario it is. So if you look at it that way, almost every day is a disaster for us. But yeah, again, this is a little above that. So when you have insufficient staff, breakdown of communication networks and chaotic scenarios. So all the plannings and staff training protocols, do you have protocols such as those which can train your ward staff? I mean, those staff who is working in other wards, maybe a dialysis ward staff may not be trained in what can happen in an emergency scenario other than BLS. So should they have some cross training? All these things should be thought about. Again, security is a big problem when you have an incident or a disaster, or be it in hospital, out hospital. You would have seen in Amri when you have 94 children or 94 patients who died. If one patient has a negative outcome, from 5-6 relatives keep barging in. Now imagine 90 or 100 patients having the same. It's just a matter of time with it before you get beaten up. Looting of theft and medical supplies happen during all chaotic scenarios, and no one is able to notice. That is few of the things that you have to worry about. Let's do a scenario for thought. So now let's take Dr. John, who is doing his rounds in the ICU one day. Okay, let's make it Mrs. John. So she finds that she feels some awkward smell, probably a burning smell. She is suspicious, and then she calls the fire squad, in-hospital fire squad. And then the fire squad comes and checks all the equipments and clears, hey, there's nothing wrong here. It should be fine. And then they are all settled. But then she thinks, what if actually a fire had occurred? What would I have done? So this is just an example. I won't be able to discuss all the scenarios in that you can pick up. So I'm just giving a track of how you can think. So in case of a fire, are there fire sensors and fire alarms working in your hospital well? Are there escape or exit routes marked well and kept open? The ways can't be blocked. We had a few years back, I remember one of my teachers telling me they were doing an inspection for the fire exits, and they opened the first one and the second one, the third one, they opened it, went into a cupboard. It is not even connected to the exit. So make sure that all exits are marked well and is open. It has to be kept open and just to be going outside. How do you alert the central command? Do you have a system to alert the central command which activates everyone in the hospital to take steps and call for external help if required? Can your trolleys or patients be mobilized easily? Will you have to carry them, or do they have trolleys, or you have ramps where you can push the patients to safety? You have areas to save them, to keep them safe. Are there fire extinguishers, and if yes, where is it kept? Are they kept in tactical situations, where strategic points where it's required, where it can be used well? Are they expired? Where do you find the expiry date? And are they well pressurized? Do they have a pressure monitor, or has it been weighed? For example, a CO2 extinguisher cannot be does not have the pressure monitor gauge on it. It's based on the weight of the extinguisher, while the ABC extinguishers have a pressure monitor which has green and red, so you can pick up. Are your staff well trained in using the extinguishers? That is another big question, because no point of having an extinguisher not knowing how to use it. So this is again common sparking points in a hospital area, especially in ICU. These are all tendencies to happen. So faulty equipment, overloaded power circuit. So you probably won't remember what we learned in school physics. Each of these plug points in the hospital has either a 15 ampere or 20 ampere line. And 120 to 240 volt can go into it. So if you calculate the power, around 1980 is the wattage that can go. To be safe, you always prefer to have only less than 80% of that wattage connection to it. So if you have an extension cord and put 3 ventilators on top of that, it may not tolerate it. So these are all overloaded power circuits, power outlets. It can cause fire. Similar damaged wiring. Wiring has to be checked. Was the improper grounding of electricity is done? Any static electricity or any battery malfunctions? These are things that you should be looking into. So this is a surge capacity area. We have kept one fire exit plan that has been maintained. This is just an example in our scenario. And as central number, do you have a central number to call and protocols in place? So we have 50 beds in, we have 3 EDs, so total of 120 patients and beds. What if there is a surge? So what is a surge? Surge is something that can occur just more than what you have, even a small number. So I said we have almost 95 to 100% of bed occupancy all the time. So anything more than that is a surge for us. So whenever there's a disaster, be it in hospital, out hospital. In hospital, most of them are patients involved. When it's out hospital disaster, this 80-20 rule applies. So 80% of that may not be required to have a hospital in-hospital treatment, but 20% might be actually injured. But the 20% is not the one who will make an issue. The 80% ones will be the ones causing havoc in the hospital. So yeah, that is already covered. So again, imagine in your ICU or in your ward or in your peripheral hospital, you have normal capacity. You should be knowing your normal capacity of the hospital. Now imagine 5 to 10 patients at the same time. And then imagine 10, 20, 50 patients coming at the same time. Do you have a plan? Do you have a plan to refer these patients to a nearby center? Do you have a plan to adjust the current patients in your hospital, discharge them or admit them? But these are, again, if you have 500 patients at the same time, these are not just imaginary situations. Historically, these numbers actually have come as real-time emergencies and disasters. So when you have a surge, your risk element includes decreased space, decreased staff, decreased supplies, your quality of care becoming compromised, ICU expansion, you have beds for ICUs, ventilators, etc., and other resources. So again, when we had multiple mass casualties, so when we keep doing, we have some plans in place. However, we still find a lot of issues. So we had most of them are RTAs on one of these incidents where you can see 20 patients coming together, 3 priority 1s, 13 priority 2s, and 4 priority 3s. This was a little bad for us. So that day we found the difficulty in referring patients, admitting the severely operated ones, needed more OT rooms, operation theaters. However, we couldn't find enough because there was only 2 teams to operate. Ground was difficult to manage because everyone came with a relative and the security had to help us out. We had to have external help some little bit. and some powerful people always walk inside and try to gain attention there, and you have to deal with them too in the media. So yeah, so have you done a risk assessment at your institution? Is a question that you should probably ask after this at this point right now, and probably later on after this class, and think and make plans for the same. And yeah, thank you so much. This is just part of our department. The entire photo is difficult to obtain because of a big department. Anyway, thank you so much. So I hope.
Thank you so much, Dr. Paul, for your presentation, and also showing us, giving us practical insights from CMC Vellore, and offer valuable lessons for all in our healthcare facilities. Next, we'll hear from Dr. Pritesh about growing challenges of climate change and its impact on healthcare.
So good evening to all of y'all, and thank you so much, CMAI, for this opportunity in terms of this particular webinar regarding disaster management, especially in the context of healthcare facilities. So I'm actually going to be covering a component of how climate risks pose a threat to healthcare facilities, and why is it important that we as administrators, as healthcare professionals, required to be aware of some of these climate risks, and what is it that we can actually do to be able to reduce the impact of this particular climate risk. This is probably going to be discussed in the future sessions. Okay. So this is basically a picture of various disasters across India where St. John's, where we actually have a disaster management unit, has provided disaster relief. But let's go to the more important aspect of why exactly we are concerned about disasters. We have close to around 25% of the world's landmass and 75% of the population that are at some form of risk of disaster. 60% of the major natural disasters reported in the world occur in the Asian region, with India being the highest disaster-prone country, in this particular region. So on an average, we have around 8 major natural calamities in India every year. And some of these include floods, drought, cyclones, earthquakes, river erosions, and landslides. So as far as India is concerned, India has a varying kind of climate vulnerability due to various reasons. One, there is a geographic diversity. We have the coastlines, we have deserts, we have places that are exposed to extremes of temperature, especially in northern parts of India and certain parts of southern India. We have large areas which have dense populations. So if we actually take some of the central Indian and the North Indian states, the population density is extremely high, which can lead the place to be more vulnerable as far as disasters are concerned. There are infrastructure gaps. So unlike many developed countries, we are still a country that is struggling with extremes of infrastructures. We have cities which have possibly good infrastructure. At the same time, we have a crumbling infrastructure in several cities due to aspects such as overpopulation, overcrowding, etc. And lastly, we have socioeconomic challenges. We have a wide disparity as far as the rich and poor in our country is concerned. So if you look at this particular map, which looks at the levels of exposure of different countries to natural hazards, we can see that India, as far as this particular map is concerned, is at a very high level of exposure as far as natural disasters. If we now look at this particular map, which looks at the risk of death from disasters, right? We can see that the Indian subcontinent has a huge number of areas which are in this zone of high to medium risk as far as death is concerned from natural disasters. So let's see some of the key climate disasters affecting healthcare. As far as India is concerned, we have extreme heat waves. In certain areas, we have temperatures exceeding 50 degrees centigrade, especially in places like Delhi, in central India. We have equipment failures as a result of extreme, heat waves and electricity, fluctuations, increased cooling costs, as well as surges in heat-related illnesses. The other extreme, looking at monsoon flooding. So we have seen certain photographs shown by the previous speakers. Peniel showed us photographs of Assam, of Kerala, where there can be facility damage. There could be access disruptions where people find it difficult to actually come across to these hospitals. We have seen this, in areas like Assam, where people get stranded in the middle of the river Brahmaputra and are not able to access healthcare, which is largely, along the mainland as such. There are outbreaks of waterborne diseases, and these can also occur in healthcare settings. Cyclones in coastal regions. There is a facility destruction. There are power outages. There are challenges with regard to evacuation from these areas, especially in the acute phase, of the cyclone hitting these areas. Droughts, where water scarcity, affects sanitation. We have water-dependent treatments, which are largely impacted in such areas because of drought, as well as we have the challenge of staff and patient hydration needs. In fact, very recently in Bangalore, in a city like Bangalore, there was this challenge of water scarcity, and there was the challenge of staff and patient hydration needs that were faced in many settings, including St. John's Medical College, which is located in the heart of Bangalore. Air pollution crisis. We have actually seen snapshots of Delhi, where there are respiratory emergency surges. There are challenges for health workers as well, in terms of reaching healthcare facilities, in terms of coping with the large volume or the surge capacity as far as the emergencies are concerned. And lastly, there are ventilation system compromises, especially if the air conditioning is not functioning very well, if there is a poor servicing of air conditioning in these zones. Landslides in the Himalayan states. I especially remember the situation of Uttarakhand, where we worked with multiple agencies, and there are remote facilities many times that are actually cut off. There is also damage in terms of critical infrastructure, as well as medical supply route disruptions. So if we look at the unique vulnerabilities as such, there are infrastructure gaps in terms of limited backup power capabilities. We have smaller facilities that still have a challenge with regard to having certain backups in case of failures of power in their facilities. And this has been seen largely in also disasters where there is actually a cutoff of the requirements to run actually some of these power capabilities. So there is during the Kerala floods in 2018 an example of a very large corporate hospital as well as a medical college hospital whose backup generators were actually affected because of diesel not being provided to these zones due to these areas being cut off. And there was a huge crisis in terms of their ICUs where patients could not be sustained on ventilators. The component of aging facilities. We have very old hospitals in certain places, crumbling infrastructure, and in addition to that, inadequate building codes. The location where hospitals are actually constructed, the way in which the construction itself takes place. Let's say in areas which are earthquake prone or which are low lying as such to be prone to flooding. In terms of urban density as such, we have facilities in low-lying areas where during floods, urban flooding as such, these can be affected. Limited evacuation options, especially if there is poor planning in some of these areas, as well as a concentrated demand as far as emergencies are concerned in certain facilities which are more easier to access in urban areas. There are limited preparedness plans. So one, there's a lack of awareness among personnel itself regarding preparedness plans. There's a lack of training that actually occurs among these personnel, as well as there is accessibility issues in terms of sometimes actually activating, some of these preparedness, plans itself. An example that was, given with regard to fire extinguishers in the earlier presentation, in terms of not knowing where they are, as well as, not knowing actually how to operate some of these, systems. A lack of commitment and willingness is also a key factor in our settings, where political commitment needs strengthening. There's a lot of paper-based plans which are put out, but they don't translate into reality. And added to which there is the aspect of corruption, which actually helps certain facilities bypass the necessary preparedness and be more prone to disasters. There's a lack of robust policy and planning measures. So if you actually look at our disaster management plans, either of the district or the state, many of them are largely paper-based, wherein actually they are not looked for proper implementation. There's also a lack of specialized training programs. I still remember an incident where there was the tsunami that actually hit Japan. And suddenly, we actually got a circular, from the state government, saying that we are planning to send relief teams to actually provide relief in Japan. We require, you all to provide 20 names who would be actually required to go at short notice to provide relief, in these areas. Now, the challenge here was the nuclear facilities, had actually been affected. There was a leakage, from the nuclear reactors. And people, who were actually called in did not have any kind of specialized training, which was a huge challenge in terms of volunteering, as well as, in terms of, the fear factor among, such personnel who are responding to these disasters. Essential supply stockpiles, could be lacking. There is a lack of community engagement in terms of planning, as well as, in terms of ensuring that there's participation from affected communities in disaster relief in various centers, as well as a lack of intersectoral coordination. There are multiple sectors requiring to actually respond to disasters, and this is actually lacking in various states, as well as various settings. There are a few case studies in terms of learnings. If you actually look at various situations, such as the Kerala floods, I mentioned about the corporate hospitals, where actually essentials, were cut off. The Odisha cyclone, where in 1999, as well as thereafter in 2005-06, there were huge damages, wherein they realized that healthcare facilities were struggling to cope as far as responding to the cyclone is concerned. The tsunami, which was a biggest learning as far as our country is concerned, as well as certain urban flood settings, such as Bengaluru and Chennai, where we had floods affecting some of these cities and challenging the healthcare systems. So these are some pictures of newspaper clippings as such. This is actually a picture from Chennai in 2021, where they actually show how unprepared the hospitals are, both private and government, in terms of responding to the floods that actually occurred in Chennai. This is a picture from Assam, and you can see how ill-equipped the hospitals are in terms of responding to the huge surge of patients. You can see certain beds where there are more than one patient on a particular bed, and it's a challenging situation in terms of trying to organize a better response in such facilities unless things are well prepared for. This is a picture from Andaman Nicobar Islands. In fact, this is the primary health center at Theresa, where the entire health systems were actually destroyed. And we had a lack of people, trained personnel who had actually fled, from the scene and, who were not there in the hospitals to be able to run these healthcare facilities. So there are challenges in terms of funding gaps, in terms of, looking at budgetary, constraints for a variety of reasons, including, corruption. There are coordination, challenges between different departments who require to actually undertake response, as well as there's a lack of knowledge sharing in terms of various, sectors who have actually learned certain, good lessons, but are not able to translate that into, knowledge sharing for others, to be able to implement. So what is, the need of the hour is looking at what we have called climate resilient, facilities, right? So very recently, the WHO and the UNICEF actually released a requirement of what they call climate resilient and green healthcare facilities, right? So green and climate resilient, healthcare facilities, wherein they hope that facilities are able to cope with the necessary, climate changes, as well as, ensure that they are, resilient in the, face of, various climate disasters that affect, various parts of the country. So if you look at lastly specific examples, I've taken the example of, Bangalore, which can be, vulnerable to, various climatic issues. So we have currently a huge amount of warming that is now happening in Bangalore. Currently, the temperatures in Bangalore, are probably 2 to 3 degrees higher as compared to what they were, as far as, earlier years were concerned. We have certain areas that are, much hotter. So we have heat island, effects in, various parts, of the city. And this has been exacerbated by concrete expansion and reduced, green cover. So there's been a very erratic and huge expansion of the city, which has been very unplanned, which has led to also aspects of, water scarcity. So there's a depletion of, groundwater resources. There's a huge dependence on Kaveri river water, supply, which provides, water to both, households as well as, healthcare facilities. There is a component of other extremes of, intense rainfall, leading to, urban flooding. There's a drainage system, overload, which is, highly blocked, as well as, which is unable to actually take the load of, heavy rainfall, as well as there is, due to, rainfall, certain campus access disruptions. Lastly, there's also the power reliability issues. So there is a grid instability during, extreme weather. And there is, a challenge of essential medical services, vulnerability due to, power reliability, issues in certain areas. So this in a nutshell is various ways in which healthcare facilities are affected by, climatic disruptions. And hopefully in the next coming sessions in future, we would be able to look at how we as an institution at St. John's have been able to cope with, some of these changes, especially, in a scenario like Bangalore, as well as examples of, how other healthcare settings across India have been able to cope with, different disasters and be resilient, to them in their settings. So thank you very much. Over to the next speaker.
Thank you, Dr. Pritesh, for highlighting this critical environmental considerations. And if you have any questions, you can put it on the chat box. After this next presentation, we'll have our panel discussion. And for our last speaker, I now invite Mr. David Duncan to share his international perspectives on practical risk analysis and mitigation strategies. Over to you, David.
Thank you very much. Can someone confirm that you can see my screen, pulling it up here?
Yes, you can see it's loading. Yes, we can see it. Yeah.
Okay, thank you. Well, thank you again for inviting me to be here. Special thanks to CMAI and the organizers for inviting me. I've benefited a lot just from listening to the other speakers, and hopefully I'll be able to add value to that discussion by talking about various practical risk analysis strategies, specifically for hazard mitigation. And what we'll be doing here is comparing risk assessment tools for emergency preparedness. So the purpose of today's presentation is to review and compare internationally recognized risk assessment tools and best practices and discuss their practical application for healthcare organizations. The four that we're going to look at specifically are the FEMA's Threat Hazard Identification and Risk Assessment, the strategic tool for assessing risk developed by the WHO, the very common one that's used in the US, Kaiser Permanente's Hazard Vulnerability Analysis, and then we're going to also look at the Hospital Safety Index, which again is another WHO production. The second thing that we're going to do is to introduce a Microsoft SharePoint application that incorporates many of the features of the international best practices for hazard mitigation. That tool is known as Redify RM. In full disclosure, it was designed and developed by my organization, Redify LLC. And the point here is that many of the tools that I'm going to show you, actually all of the tools that I'm going to show you that are internationally recognized best practices, tend to have some gaps in their applicability for healthcare organizations specifically, but there's a lot that we can learn from each one in order to design something for our facilities. What we've done with Redify RM is actually try to incorporate many of these best practices, the features that are applicable to hospitals and other healthcare organizations, and make them applicable in one tool using a Microsoft product, because many organizations already use Microsoft. They mostly have a Microsoft business account. So integrating a SharePoint application is very simple. It's very easy. The IT professionals at the organizations tend to like this because there's a lot less concerns about information security, et cetera. So we'll just go ahead and get started right away and start looking at the individual internationally recognized best practices. The first one is THERA, the Threat and Hazard Identification and Risk Assessment. It was developed by the Federal Emergency Management Agency in the United States. It's a national level risk assessment framework. It follows a simple, well, maybe not so simple, it is fairly complex, but the four-step process that it uses is identifying threats and hazards first, and then developing a risk context, defining capability targets, which is the real strength of the THERA, and then applying results to the preparedness planning. So THERA is widely used by government agencies, emergency management professionals, and public safety organizations at the national, state, and county level mostly to enhance national and regional preparedness. It aligns with the country's national preparedness goal, and so it's a very good tool for county governments to utilize because it all aligns with the various levels of government. The one key strength of THERA that I like about it specifically is its ability to integrate capability-based planning, which is something that hospitals need to do more of. All healthcare organizations need to look at their capabilities and incorporate those into their risk assessments. This helps the jurisdictions to prioritize resources for both response and mitigation. However, I do want to point out that the focus is much broader than hospitals. It's less tailored for healthcare organizations because healthcare organizations tend to need a more hospital-centric or facility-centric risk assessment tool. However, there are certainly lessons learned from the THERA that we could implement into our own risk assessment tools. The next one is the WHO's STAR, or I'm sorry, let me go over a couple of these pictures here just to really quick. I know we're, I think, getting a little bit short on time, so I'm not going to spend a lot of time on this, but I just wanted to share a couple screenshots of THERA. And the emphasis here on this slide is that you can see all of the various core capabilities, and they look at earthquake, cyber attack, flood, active shooter, hazmat. These are hazards, and then they say these are the likely capabilities, core capabilities that will be impacted by these various hazards. So that's one of the first steps of the process. Another one is to, when you're doing an assessment of your gaps, your capability gaps, they use a POETI process, which you look at planning, the organization, equipment, training, and exercises. And this is just an example of how you would break that down further. Again, we're looking at the capabilities and incorporating that into our risk assessment strategy. And then here's a broader example where a capability target was identified, the current capability was identified, and then the capability gap is identified. and then analyzing that through the POETI process, they provide more detail as to what the description of the gaps are, so that a community, city level or county government, state government, they can take action appropriately to mitigate the risk. So the next tool we're going to look at is the WHO strategic tool for assessing risk. This is a very comprehensive global risk assessment framework designed primarily for public health systems, but there again are elements that can be adapted to the facility level, certainly more so than the THERA. It incorporates a traditional risk matrix approach that I think we've seen already in today's presentation, evaluating both likelihood, impact, and what they've added to the STAR recently is a resilience capacity assessment, which makes it a very structured and data-driven method. But unlike the THERA, the STAR, WHO's STAR risk assessment places greater emphasis on health security threats, such as pandemics, infectious diseases, and climate-related hazards, specifically as it affects the environmental health and safety of a community. It is widely used by public healthcare organizations, governments, and some hospitals, but particularly in low and middle income countries. That's, it's actually becoming more utilized in even developed countries, actually. But I think initially it was developed not primarily, but certainly with an emphasis on helping low and middle income countries truly understand their risks. And the main drawback of the STAR is that, again, it's broad in scope as well, which makes it more suitable for health systems, especially at the public level, versus individual hospitals. But again, just like the THERA, there are certainly elements, especially the resilience capacity aspect of the STAR methodology that would, if a hospital reviews that and looks at that and studies the STAR methodology, they would get some value if they added that methodology into their own individual risk assessments. This is a picture of an example of the risk identification and analysis phase of the STAR. So you can see on the left that there's just an incident, which is kind of contextualizing, not really contextualizing, but just identifying an incident, and then they look at the consequences across staff, the facilities, and other resources, as well as operationally. And then on the right side there, you can see the risk evaluation on impact and likelihood, and then what the overall risk score. So this then leads to a risk summary or a risk profile. So all of the risks get categorized from, I think, extreme to low. And so here, this organization, this public health system didn't have any extreme risks, but they started out at high. And then, so they list all of the different risks related to the hazards or the incidences that they've identified. And then they show that what preparedness actions are required. Again, prioritizing minimum preparedness, additional preparedness, et cetera. This is just another continuation of that first or that second illustration, where they show that they goes to all the way to very low. So it lists all of their risks in terms of their risk level, and then gauges their level of preparedness. And then again, this is a risk matrix that's used by the STAR, whereas we're used to seeing basically a numerical system per hazard. This one categorizes the hazard according to the risk matrix and lists all of the individual hazards inside the matrix. So you can see, for example, in this one, the fecal-oral diseases, airborne droplet diseases are one of their higher level risks, all the way down to radionuclear exposure is one of their lowest hazards, probably most likely due to the fact that the likelihood is very unlikely. Again, this is another methodology that can be used by hospitals. I think a lot of hospitals do use a risk matrix methodology, and others use an old methodology, or not an old one, it's still being used, but one of the original HVA models that we're going to look at here very soon. So that brings us to the Kaiser Permanente hazard vulnerability analysis model, a risk assessment tool. HVA was a term that was coined or became popular when it was used by the Joint Commission in its standards quite a number of years ago. I think back in 2007, somewhere around there. So the Kaiser Permanente Hazard Vulnerability Analysis Tool, it's one of the most commonly used risk assessment tools in hospitals, especially in the United States, Canada, and I think in some places in Europe. I'm not sure how widely used it is used in like countries like India and other Asian countries. It would be interesting to learn that from this group if you are familiar with this or have used this before. The Kaiser Permanente model provides a structured, easy to use framework for evaluating hazards based on probability and impact, which is what we're all used to. But several years ago, they also added another column in the assessment, which is preparedness level. And I'll show you an example of that here in just a second. The tool is widely used in US hospitals because it aligns mostly with accreditation and compliance requirements. What made it most popular is that when that model was introduced by Kaiser Permanente, it was Joint Commission actually listed it as a best practice. And so as soon as that happened, it became the #1 most widely used tool in the hospitals, because hospitals are afraid to sometimes be innovative and creative and go beyond, if Joint Commission has put their stamp of approval on it, then they do it just that way, and they don't look any further. And there's nothing wrong with the HVA that Kaiser Permanente has developed in terms of its at a fundamental level, but it's missing some elements that I'd like to point out. The key strength is its simplicity, so it allows the hospital to quickly assess and prioritize risks without requiring advanced analytics. However, that's also one of its biggest weaknesses, is because it lacks a methodology for objectively measuring impact. So it doesn't provide a structured way to measure the true severity of hazards, which can make risk prioritization somewhat very actually subjective. Here's an example of the HVA model. And again, you may be very familiar with this. It does not utilize a risk matrix approach. It's just a simple Excel sheet essentially that has a series of formulas built into it. And you enter the information quite subjectively as it relates to likelihood. And then you guess at the human, property, business impact. But then you also now add the level of preparedness and internal response and external response. And that's supposed to then be the measure of your capability to some degree, to use that term loosely in this context. And then that generates a risk score for that hazard. And then at the bottom right corner, you see that overall its all hazard score is 11%. The challenge with that is it really doesn't tell a story. It really doesn't show, what does that 11% mean? What do we need to do? Is that good? Is that bad? Does that number need to go up? Does it need to go down? So there's some ambiguity a little bit in this type of risk assessment, even though it is accepted by accreditation agencies and regulatory authorities as being an HVA. And I do apologize for going fast. Again, I'm just trying to be cognizant of time. Hopefully you may be jotting down some questions that if we have time, we can talk about here in just a little bit. The next one is the Hospital Safety Index. This is a very good tool. Explain why I think it's a good tool here in just a second. Again, this was developed by WHO. It's a global tool designed to assess hospital resilience and safety in emergencies and disasters. It evaluates a hospital's ability to function both during and after, and it considers factors like infrastructure, emergency planning, and resource availability. Unlike the other models like the Kaiser HVA model, the HSI, the Hospital Safety Index, provides a very objective measurement of the hospital's risk level, which makes it a great complement to existing HVAs. So if your HVA tool lacks the ability to incorporate some level of capability assessment, I would highly suggest that you look at the HSI. It's very comprehensive. It's very long. It does take some you have to study it and learn how to use it. It's wise to train a team of people on how to utilize it, because you will need disciplinary stakeholders to be involved in the process. But the outcome of that is a tool is a system that allows you to incorporate that into your actual risk assessment. So it fills the gap where that the impact analysis needs to come into your risk assessment. It really fills that gap nicely. And you can pick and choose from it based on your facility's needs. If you're a smaller facility, as what was mentioned earlier, you're going to need much less of the content of the indicators. And if you're a large facility, or even a suite of facilities like a healthcare system in a tight geographical area, you can use that at a system level. So government and healthcare administrators like to use HSI to prioritize investments. So it's a really good tool specifically for structural mitigation when it comes to hospital resilience, especially in disaster-prone regions. However, it does lack the all hazards flexibility of the Kaiser model. So it's better suited for structural assessments, so rather than like daily operational risk assessments. So it really does target mostly the structural integrity, the safety from a structural perspective. Really quick, here's just this is a very small snapshot of the HSI. And again, I encourage, and I think Pranayal has created a link or added a link to his presentation that you should be able to visit. And I would encourage you to read this and understand it, because it is a good tool to add to your risk assessment process. So we're going to then move on to the Redify RM application. RM stands for risk management. Again, it is a Microsoft SharePoint based HVA tool. I can explain what that means a little bit more for people who may be uncertain or confused about that. But again, it was developed by my company, Redify LLC. It's an advanced, we like to use the term advanced because we believe that it is advanced risk management tool that helps hospitals and healthcare organizations assess, prioritize, and mitigate hazards. Where other tools are globally utilized at the government level, this tool is specific to the facility level. So even in a suite of hospitals or healthcare system, we would recommend that each facility do its own risk assessment using this tool. Again, it's designed using the Microsoft 365 SharePoint framework, which makes it easily accessible and cost-effective compared to other high-cost risk management software. It also avoids any concerns regarding information security and server hosting and other things like that. Redify RM incorporates strengths from both Thera, the WHO STAR, the Kaiser Permanente and the Kaiser Permanente HVA, creating a well-rounded risk assessment process. In theory, it does also, from a, this is the word I'm trying to look for, as it relates to HSI, it uses a similar approach to identifying vulnerabilities that HSI does, but where HSI, again, is really heavily structurally related, the Redify RM is a little bit more high level, and it does get into the structural integrity issues, but just not as deep as the HSI tool. Unlike the Kaiser HVA model, it includes a very structured impact analysis similar to the HSI, ensuring that risk assessments are certainly more objective, which is really needed. Redify RM, we believe, is an ideal choice for hospitals and emergency planners in hospitals looking for a very user-friendly, simple, yet comprehensive risk assessment tool. So I'd like to take you through some pictures really quick of the tool. I was going to do a demo, but I think for time purposes, this would be much faster. And if there's any opportunity in the future, if anybody would be interested in doing another webinar just as a demo of the product, I would certainly be happy to do that. So when you deploy the application to your organization's SharePoint site, designated SharePoint site, and you open up the app, this is what you're going to see. It's just the home page, and it just kind of describes the different 4-phase process that's involved, describing the Redify RM's risk management framework. Next, we're going to go on to one of the primary key one of the key features. The first key feature is the hazard vulnerability assessment. This assessment helps organizations evaluate their overall preparedness across multiple dimensions, or we like to use the word core capability in alignment with the Thera model. It assesses readiness in key areas such as infrastructure, security, healthcare services, human resources, logistics, and communication. Each one of those has their own series of performance indicators. There's over 600, in total. And you can see on the slide here, just for the area of environmental health and safety, there are 140 different indicators that you're going to assess as it just relates to safety. This structured evaluation allows organizations to identify gaps in their emergency preparedness plans and certainly prioritize the improvements. These gaps are identified as vulnerabilities and incorporated into the impact score. So if it's not a yes on your capabilities assessment or on your vulnerability assessment, so a yes answer becomes a capability and a no answer remains a vulnerability. And then those vulnerabilities are then assigned to threats. So when we do the hazard impact analysis, which I'm going to show you in a second, it actually has a very objective, quantifiable evaluation methodology, scoring methodology for impact. So that's unlike traditional risk assessment tools that focus simply on just a very simple probability times impact subjective scoring methodology. RedifyRM integrates organizational vulnerabilities, making it more as a way to measure impact. So you're not guessing at the score of impact. It's not it's a 2 or a 3 or a 4. You actually have a very objective tool that's telling you what that score is, and it automates the scoring. So the results from the assessment feed directly into the impact analysis, ensuring that decision making, and this is very important, decision making, especially at this leadership level, the facility leadership level, is based on a comprehensive risk analysis that incorporates preparedness vulnerabilities and capabilities into the equation. So again, the highlighted area there just shows that we're looking at those 7 core capabilities, and then here we're assessing it using over 600 key indicators. Moving on then to the hazard identification, we have a module that provides a structured framework to identify potential hazards that could impact operations. It includes a very pre-populated database of common hazards, such as anything from natural disasters to cyber attacks. You can see there on the left in the highlighted area. We've categorized the hazards according to natural, accidental, intentional. We've actually carved out biological as its own threat category. You can also through the app add new hazards, and you can delete hazards that don't relate or not significant to your organization or to your area. This ensures that risk assessments are tailored to the unique needs of each hospital or health system. The other thing that I want to point out, I don't have a picture of it, but when you do the assessment, the impact analysis, it gives you an opportunity to add context to each hazard. So once you've identified the hazard, instead of just saying landslide, for example, you might specifically say this type of landslide has occurred and it's created this type of a situation, so that when you're doing your preparedness, your planning, your mitigation, even when you're conducting training and you're designing exercises, you can use that same context throughout all of your preparedness activities, which again is something that is lacking in hospital risk assessments. They often lack connecting the dots between the risk assessment, the risk analysis, hazard mitigation plans, et cetera, all the way through each phase or each step of the EDP or the emergency and disaster preparedness process. So we've tried to make sure that we can incorporate that here. And it's very helpful, again, not just for decision making and planning, but it's also very helpful for those hospitals that seek accreditation and need to meet different regulatory concerns. Unlike many traditional HPA tools, RedifyRM allows for contextual, I already covered that, so we contextualize the threats. So if you're using the tool, can define the severity and likelihood based on a incident or context, real world conditions, rather than relying solely on historical data. And then by systematically identifying and categorizing hazards, organizations can develop a very proactive approach to risk management. This is the actual hazard impact analysis part. So I'll just walk you through this. So once we've gone from the hazard identification, we then move to hazard analysis. Again, if you look on the left of the screen, you'll see that we are going to do this exercise for every category of hazard. And then in the main body of the screen, you see each hazard that was identified during the hazard identification process. Again, this allows for an objective framework to evaluate how hazards will affect hospital operations. This addresses one of the biggest weaknesses of other tools, which lacks that structured method for measuring impact. And the way we're going to do that is we're going to click on the impact, where you see that button there where it says impact. For hurricane, for example, you can see impact 4.5. We've already assessed this, both from probability as well as impact. And so when you click on the impact score or the impact button, it's going to bring you to another page that just looks at the hurricane hazard. And there again on the left, you see all of the different core capabilities. So what we're going to do is we're going to look at each hazard based on each core capability, and we're going to ask a series of pre-populated questions. Basically, we call these threats or harmful events. So we're going to ask you, or you're going to ask yourself, will this hazard do this, or is it likely to have this? So if you check the box, a series of vulnerabilities that were attached to that threat are going to, if they were answered no, automatically then become part of your objective impact analysis. So you don't, again, you're no more are you saying, you know, is it a 2 or is it a 3 on the impact scale? You're looking at every possible threat that could happen as it relates to this hazard. You're categorizing it and breaking it down according to a core capability, and then that's going to give you a list of vulnerabilities. Eventually, it'll give you a list of mitigative strategies as well. So if we keep going through this, we go then to the mitigation plan, which is probably one of the really neat features about this that is lacking in a risk assessment tool. Often the tools get you to the point where you identify the risk and prioritize it according to a risk rating, but then there's not a good tool that then says we're going to move forward and mitigate the hazard. So here you have the corrective action. I'm just going to go through this very quickly for time's sake. What this does is it automatically returns a corrective action for every vulnerability that's been identified by the system. When you get to the you can then create a plan of action for each strategy. And when you click on that button, it opens up a plan of action where you get to identify, the overall due date of the correct action. And then as you list individual tasks, the system will automatically, return a progress report. So you can see this one, for example, as a demonstration is at 67%. You can also see that you can assign owners to each of the tasks based on their subject matter expertise in the organization. Then you can click updates and the system will track all updates as it relates to the progress of each task. And then finally, you can actually, using the tool, you can message and communicate with all of your different stakeholders, and it's broken down per task. So you can go back and look at this down the road. The other thing that we're really happy to be able to provide is a very dynamic system for reporting. So you see here on the screen, this is the top level of the report that you get. And again, I hope I get a chance to explain this a little bit in more detail, but just from an illustration, this is probably something new. I don't know your risk assessment tools, how well that you are, breaking out your reports. But this allows you in real time, any changes that you make in the platform, it updates the report in real time. There's no delay. This is the bottom half of that front of the risk summary. You can see here that we have a hazard prioritization list, but then also on the left, I do want to point out, you can actually score the organization. We call it the preparedness index, and that's a value of 1 to 100. And obviously we want to be as close to 100 as possible. And you can see that there are a total of 15 hazards identified that are affecting the organization. There's a total of 73 threats, and then the total mitigations that are required for the organization are 526. So that's a very high level view. This is a tool, this is just a summary slide where I wanted to do a crosswalk table. Again, I believe these are going to be, hopefully these slides are going to be made available to the group after the presentation. I think it's also being recorded and going to be made available later. So I would encourage you just to look at this slide and see what the comparisons are. And then you can choose, what's best for you. That's what I recommend mostly, is that you look at these and say, this is what's best for our organization to get us to a high level of preparedness. So with that, I appreciate, again, your time and your patience, and thank you very much.
Thank you, David, for taking us through all the tools and also bringing in the global perspective in our discussion. So we have heard from all our four excellent presenters. So now we'll move on to the panel discussion. Can I request all the resource persons, all the speakers to switch on their cameras? Let me add each one of them. Neeraj, are you there? Okay,
Emergency department, so.
okay, totally understandable. Yeah, so now, no, we've received a couple of questions, and I also have some. Okay, is there? So, you're muted. Will you be
Unmute.
able to participate for the Q&A, or you are in duty? For you, Niran. You are muted. Okay, okay, we'll.
Unmute, you're saying something.
Okay, sure. Let's. I think my first question is to Peniel is, I mean, what would be the minimal risk assessment process a small healthcare facility should implement with limited resource? Because we're talking about mission hospitals, and here we see most of our hospitals limited resource, and also in terms of human resource wise, also less people are there. So, what is the minimum that we can do?
As far as risk assessment is concerned, it's just like diagnosis, medical report. You have to do extensively, comprehensively, but then action taken can be in phased manner. So that's why I said you have to prioritize the areas that you know it's instant threat, and then you have the capacity, and therefore with little more added capacity, you undertake those measures. Then phase-wise you can go into. We cannot, no hospital can resolve 100% crisis. So start with whatever priority and core areas need to be taken. That's why I engaged Dr. Neeraj, because most of the hospitals, this critical areas need to be really undertaken. This risk assessment and then action. Yeah. So what David Duncan shared also, that will highlight, the areas, the hazard, the risk, and existing capabilities, vulnerabilities. Thank you.
Thank you, Peniel. Now, Neeraj, you should be able to unmute now.
Yes.
Okay, so my question to you is, how do you prioritize which emergency service must continue during different types of disaster?
Okay. Again, I would emphasize the importance of a disaster triage at that point of time. So when we have, when we had COVID, our triage systems had to be a little bit modified. Am I audible? I mean,
yes, we can hear you.
So we had to modify our triage systems a little bit, and we know that most of the patients with COVID had come with lower saturation during the time. So we had to cut down on our saturation targets in our resuscitation area, because otherwise all the patients will end up in our resuscitation area, and it's not easy to manage them. So this is in view of emergency I'm talking about, because I'm coming from a background of emergency medicine. So there, what we could do is saturation normally more than 92 goes into RR, or 90 more than goes to RR. We brought it down to I remember 80 at that point of time, because many of the patients were requiring RR. So only very, very sick patients, less than 80 saturation would go to RR, and those got priority treatments. Again, we realized that and as part of a surge management, the best and the safest surge capacity area is their own homes, like own house. So many of them are home quarantined, and I'm pretty sure many of the hospitals are the same. So identifying surge capacity and trying to filter out all the patients who are not sick, or just like how the salt triad says, and you jump, you wave, or the people who can talk and walk, move off, and someone else who can see them off later. But the sicker ones need to be addressed first. So in a hospital scenario, I would say ICUs, patients who are in very critical areas, dialysis patients, such patients and people requiring oxygen, interventions basically, like which needs immediate monitoring, should be the ones who must be prioritized first. And people who can walk and run should be allowed to do so, and not sent on wheelchairs, which are probably less in number at that point of time. So I think every hospital has a different scenario. But we'll have to adjust it. We'll have to address it based on the situation you are in, and we cannot probably universalize. Make it all universal. The system that we follow in one single hospital. Yeah.
Thank you, Neeraj. Now, Pritesh, for you, what climate change impact should Indian hospitals be most concerned about in the next decade?
Well, I think, to be honest, it's a little tough to name any single climate change bit. Given the extent of, natural disasters, actually occurring, I think depending on different regions, they have to specifically look at what is it that can affect those regions, in terms of, climate change. So if you actually take, let's say, regions like the North, Delhi, right? So you can have aspects of heat, you can have aspects of pollution, which are on the increase. On the other hand, if you actually take places like the Northeast, or places down south where flooding is increasing, if you take urban settings, where urban flooding is actually increasing, that would be the priority. So there's no single answer in terms of a single hazard over the next decade. But certainly climate change needs to be looked at quite critically, and whatever measures possible to reduce this climate change, is important.
Thank you, Pritesh. Now, for David, for Indian and the South Asian context, we've looked at, also I've seen, if you have seen hospitals, many of them are in remote and rural areas, and infrastructure also are very old and not adequate. So keeping all that in mind, what kind of, the framework or a tool you think are best suited for such institutions, such facilities? You're muted.
You're muted, David.
Sorry about that. I think any tool that allows you to clearly and objectively assess your capability in those areas, understanding what your organizational vulnerabilities are, and then also factoring social vulnerabilities, because I think in developing countries and other areas that have socioeconomic issues that create issues for hospitals during emergencies and disasters, having a good understanding of that is important, and in both mitigation and preparedness. So from a mitigation perspective, we're looking at trying to change the design or location of an asset relative to a hazard, or relative to a threat, relative to a risk. So what we want to do is, first of all, be able to clearly identify what do we need to change in design, which can also include your planning, and what can we do in terms of, there's very little things often the hospitals can do as it relates to location, because we can't pick our hospital up and move it to another location, for example. However, to other points related to surge capacity, et cetera, we can identify alternate locations where we can, decompress emergency rooms and things of that. So I think what's really important is that your tool, whatever tool you use, whether it's a very complex model, which requires a lot of resources, it was mentioned by one listener already, and the concern with that, or using a tool that streamlines the process. First of all, I would look for a tool that streamlines and makes the process as effective and efficient as possible, and then make sure that it has a mechanism for clearly identifying and prioritizing, which is another important, because you can identify 500 different vulnerabilities, but you also need to be able to say, we prioritize those vulnerabilities according to how it most impacts operations, how it's going to most impact our community, things of that nature. So again, just in summary on that question, I would say pick a tool that's very simple to use, that's effective, and is simple to understand and easy to use, but that has value and quality in its ability to identify vulnerabilities and capabilities.
Thank you, David. This is for all the panelists here. And what is the single most important step and hospital administrators should take tomorrow to improve disaster resilience? Maybe we can start from Pritesh.
Yeah, well, I think, ensuring disaster preparedness plans are drawn up is the most important bit. To be able to have some sort of a vulnerability, assessment, and thereafter ensure that protocols, are actually developed and training, is implemented so as to be able to ensure that all personnel in that, hospital are aware of what exactly needs to be done in different disaster situations. I think this is extremely key, given the fact that disaster preparedness and response is in itself the most important step, rather than actually responding to a disaster once it actually occurs, right? So disaster preparedness mitigation is, I think, the move forward in terms of administrators preparing their setups to reduce disasters as well as build resilience.
So on my screen, I have David, if you'd like to respond to that.
Yes, thank you. And again, a very good question, and I think a very important one, because I think the most important thing that, among many things that they can do, that a senior leadership can do, executive can do within an organization, is to make sure that they're fostering and developing a culture, an organizational culture towards emergency and disaster preparedness. So the emergency disaster preparedness program of an organization can't just be the responsibility of a department or an individual or shared by a department. It requires stakeholder involvement across not both the organization, but even external within the community. It requires your patients to be involved, et cetera. But I think what leadership needs to do is make sure that that's cultivated initially, but then even enforced and hold people accountable to a very clear set of policies that govern emergency and disaster preparedness, and that'll influence things like a proper risk assessment and proper planning, training, and testing, and process improvement. So I think improving organizational culture around EDP is critical responsibility of executive leadership.
Thank you, David. Neeraj?
Yeah, so if you ask me what is it, so if someone asks me whether I can change my character, I would say first, if I'm making a mistake, I should first accept it. So the first step even here would be realizing that no one is safe. Everyone is vulnerable. So when I talked to one of my friends in ICU with regards to the presentation, I asked him, so do you have oxygen backup in your hospital? So he was like, yeah, our ventilators have backup for 4 hours. I said, what happens after that? So he said, one of our generators, we have 2-3 generators kept in 2 different parts. So one generator goes off, another generator. So I asked them, what if, Chennai had floods and we are quite close to Chennai. So what if a flood comes in Vellore and we are not not prone to it? Then he thought for a while and then I'll get back to you. And then he called me after 2 hours and said then we'll have to probably move around somewhere else. So that's no one thinks about it until it actually happens. So I feel we all should be first, especially when we are in a small hospital, yes, God keep us all safe, but then we should always be ready. We should know that, okay, something can go wrong anytime. And, being prepared is the first step. The rest is just to follow. So yeah, so accept that you are not going to be safe all the time. Be ready to, anything can happen anytime. That's all. Thank you.
Thank you, Neeraj. Peniel?
All have covered most of the 2 broad aspects. Is one is that individually, staff wise, what is the do they have the culture of safety? They have, if the employees are having this culture of safety, any spark, any smell, any such early, warning scent, they will take care of it. So inculcating the culture of safety, habit, behavior. Organizationally, what I generally do, I just walk into the departments and I tell them that this is the exit, emergency exit, and this is locked. Can you give me the key? So, mock tabletop exercise, formally if you're going, then mock drills. Another small test. I'll give you one example of a Northwest district, Delhi, Ambedkar Nagar Hospital. It's a very large hospital, some 400, 500 seats. So they says everything is okay. I said, I will just test one. Says, do you have power backup? Yeah, we have 5 generators, all Caterpillar, big generators. That is from my own personal experience in small hospitals. First generator is continuing, second generator is okay, third generator, this is the fuel is not there. Fourth generator, because it's from the same brand, they took parts from fourth generator and fixed on the third and second, they never replaced it. Fifth generator, they said this is just a waste. But I say, when you said, when I asked you, said 5 generators there. And it's almost in line with what Dr. Neeraj said. We have to go deep down and walk into, and then same thing happened in Nepal. That I feel very sympathetic to that lady. The key bunches are generally with the senior most sister. And that's a 3,000 bed hospital in Nepal, ophthalmologic hospital, eye hospital. And I said that particular gate number 5 and the exit is locked. She was searching from the bundle. She could not find, and finally, as Adam and Eve with nature, she said the senior lady just left few days back, retired. Therefore, I could not get the right key. So yeah, I would like to do that individually. Do they have the safety culture? And then organizationally test it. Mock drill, tabletop exercise, mock drill, and check it.
Thank you. We have some more questions that we have received, but also I would request if any of you participants were here. We know that we have taken a little bit more time, but this is an interesting topic and we have got hold of 4 very distinguished speakers. So you should be able to unmute yourself and ask now. But I also have a few more questions which I can post in between if nobody's asking. If while you are preparing your question, one is, I think people from the hospital should be able to answer this. Why ISO standards are not seriously taken as a compliance in any institution while being awarded license or clearance? Why several ISO standards are not so well tried to be integrated in disaster management sector in India? So this is a very heavy one, and people who are in hospitals, I think, should be able to respond to that. Yes, please go ahead. It's open to all.
Yeah, let me give a very quick and a little funny answer. The Armory Hospital had ISO certification, the latest, okay, in Calcutta. And then another very big hospital, 6-story and 300 some bedded hospital. They have their, Hall of Fame, hundreds of certificates. And when I walked into with the executive director, he's not able to tell which certificate is for what. Third, one of our EHA hospitals, I hope EHA fellows will not be offended. The NICO unit was burned down along with the certificate. That is safety certificates, fire certificate. So these kind of pathetic things are happening. Do what you can do. And NABH has now come down to pre-entry stage, which is very good. Earlier, there was very high dream. But start with the basic things. As I say, prioritize, work on them. What is not available, what I cannot do, what is the point working on? But it's very good, ISO, but don't put the ISO certificate with all pride unless you have all the things really done. Thank you.
Please go ahead, Pritesh.
So, Abhijit, I think the challenge here in many settings is that certain initiatives are done for certification, right? For the purpose of certification, there are many things that are brushed up probably a day or two before the team arrives, for certification, right? Because the more important thing is not about quality and safety. The more important aspect is to be able to have that certificate pasted on the wall, which everybody can see. And that is, the sign of, safety and quality, and not so much the systems which are in place. So I think, what is important is a change in mindset that quality and safety, should start from ensuring systems are in place. Systems are definitely, working and functional. And it is not just, being done for a sake of certification alone, right? So many institutions take pride in the fact that, we are NABH, 5-star accredited, and for the second time, third time. But the question is, do people there, actually have the culture of, safety and quality, integrated in what they do in their daily lives? That is, I think the most important bit. And I think, it should start with every individual. The starting from the top level, the administrator itself, who can set an example. Others, also should be able to follow and inculcate that, example, and not necessarily actually do it because, there is something written in a manual, which is, being asked for them to be followed.
Thank you, Pritesh. Yeah, next is, I think you have responded to part of it in your presentation and in your response as well. So one of the question is, what are some of the key lessons learned from past disasters that hospitals can incorporate into their risk assessment and preparedness strategy? And follow-up is, how can paramedics contribute to improving communication between hospital and other first responders during disaster, especially in high pressure situation?
Right. I think the most important bit, to be learned from previous disaster situations is not to repeat our mistakes. So that is, point one, right? So a lot of, disaster situations teach us, things that we should not be doing. But at the same time, it is important, for us to remember what is it that went well and what can be, done better, right? So learning, from what we have done, as well as improving upon, what has been done, are key, I think, in terms of ensuring that disaster preparedness as well as mitigation mechanisms, are set in place in various, settings. The second bit is what I'd actually mentioned earlier in terms of sharing of, different practices, sharing of, lessons. And I think this is a wonderful opportunity, that has been looked at, as far as CMAI is concerned, to be able to bring on board various other institutions. Many institutions, from what I saw in the chat box, are in remote areas, are in difficult to access areas. And they would certainly benefit, from learning and sharing, of their experiences, which, others can then, implement. The second component in terms of high pressure situations, I think it is most important not to panic, right? It is, very important to be able to think and to be able to find practical solutions which are doable, in high pressure situations. And many a times, it's not the guidelines in the book that can, give you these, solutions, right? So we need to be able to innovate. We need to be able to, improvise and find, the right solutions as far as different pressure situations are concerned.
Yeah. Anyone else you like to respond?
I would like to respond to that briefly. One of the issues related to lessons learned is, especially if we're looking at something that derives from an exercise or an actual incident, especially an incident, is that there's a missed opportunity to actually relate a lesson learned as a risk if it's identified as a risk in the incident reporting process. So we're very good oftentimes at doing proactive, sometimes good at doing rapid risk assessments during an incident as part of the incident management system. However, after the incident, when we're doing our lessons learned, it's almost like we compartmentalize that differently. In other words, it's in a different bucket. It's in the incident report, and we manage it just through the incident. So sometimes those things never actually get transferred into a risk register, and we don't analyze it then using a risk management framework that even the organization has established. So first thing is key is to make sure that the organization's risk management framework includes a way to capture risks deriving from a real world incident or even an exercise. So there's an EDP process, but you really have to integrate your EDP process with your, corporate risk management process as well, and making sure that those have a very good, relationship and partnership is very critical. And that's another way that you can help build the organizational culture, because oftentimes, at least in my experience, it's oftentimes hard to get our EDP risks escalated to a level of senior management and executive leadership. However, they're more conscious of what's on the corporate risk register. So if we can make sure that we're incorporating EDP risks into a corporate risk register, I think you're going to do a lot better at identifying those, tracking those, monitoring those, and getting support from leadership to get those mitigated, to get them reduced, et cetera. So just make sure you're not missing an opportunity there on your incident reporting system mechanism, if it's digital or paper or whatever it is, be able to transfer those risks or over to the risk register and assign the appropriate department. It could be your emergency management personnel. It could be a completely different department with oversight of your emergency management committee. That's all based on how your risk management framework operates. So I think that's important to capture.
Thank you, David. Yes, Pinu. Yeah.
I'd just like to add also to what David mentioned, that many a times in institutions or hospitals, there's a fear factor involved in terms of reporting, certain incidents, right? So there's a fear factor that whoever actually reports an incident may actually be demoted, or certain actions may be taken, as a result of which people try and suppress some of these reporting as far as incidents is concerned. There's also a fear factor of if incidents are reported, it may bring down ratings during certain assessments, right? Accreditations or assessments. And I think that is the primary aspect also that needs to be addressed. Ensuring that employees in institutions are aware of the fact that whatever is reported is not necessarily a fault-finding exercise, but something to actually improve on the existing systems, which is true quality improvement.
Thank you, Pritesh. Yeah, Peniel?
Just the point of using paramedics in emergency response, is it a medical or non-medical? I always prefer to say that, train non-medical staff to help you, strengthening your response capabilities in terms of even triaging, in terms of even doing the first aid and initial things. In 2009, I guess, when AIIMS had their disaster management plan for the hospital, it was so broad. But when they presented the organogram for disaster response, I see from top to bottom all doctors involved, including logistic arrangement by a doctor, purchase by a doctor, shifting patient from this hospital. I mean, I asked that boldly that question, and Dr. Gupta, who actually developed this, he says, "This is hospital." I said, fine, if doctors can be utilized for the life-saving exercises, not involved in logistics, this and that. So then he sort of come down. So many hospitals, we have this problem. So just on the point of paramedic, and I don't know, in India, probably we don't have the true definition of paramedic. What we learn to grow is saying paramedic is a lab technician, X-ray technician, all those technicians. We were at times wondering if we could, we could develop this emergency paramedic training program. One of my friend, Dr. Chuni Chungat, who was the first disaster management coordinator, he is now in Australia, and he keeps saying that we need to have in India, paramedic medical emergency response team. So unless they're specifically trained and they are, they should be used for life-saving exercises, not for all this logistics, setting the setting the evacuation program and doing the fire safety and all these things, not at all.
Thank you. I think HSSC has, Health Sector Skill Council has some training for paramedics on, those who are to respond during emergency.
Yeah, there is a training, in fact, through HSSC. That's one. Secondly, many institutions now have paramedic training being undertaken, for various, sets of people. An example that comes to mind is the paramedics, who accompany actually ambulances in terms of identification of different situations as well as stabilization. not every ambulance actually has a doctor or a nurse, but it actually, has trained paramedics. So here in St. John's, in fact, we actually follow that system in terms of various assessments, at the emergency triaging itself, also having a role of paramedics, involved in terms of, this particular, triaging. The ambulances actually that go out also have, trained paramedics, who are able to assess situations, probably liaison with, medical teams back at the hospital, and try and, sort out emergencies, in required situations. So yes, there is a increasing need to be able to introduce this across all sectors and across all other regions. I mean, it's largely confined to corporate hospitals, larger hospitals, but yes, it should, I think, percolate down to smaller healthcare institutions, especially in rural areas where it can be, very useful. I can see Anju Kurian, I mean, put out a message saying, yes, I'm a paramedic, so fantastic. Glad to see, that she's actually on this call. And it's a reinforcement that, everybody is a part of, disaster response and disaster management.
Yeah, I think emergency department of CMC Vellore have started something called a stopgap arrangement, PHMMET, pre-hospital management of medical emergency. And I have taken the team to Assam and Manipur and trained, and doctors were amazed. This is going to fill up the gap. And whether it is transporting a patient from a rural center to an urban center for a specific retirement, specific care, the patient's life is saved, or continuation of medical emergency care is undertaken. Otherwise, most of the smart ambulances bring patient and their title is brought dead. So that is a huge gap, but that is, I think, in another day we can have a topic on this. I'm glad to hear about, we're glad to see the text. One even Jamia Millia, or one university, one medical college started in Delhi. And just before the Asia, what is it? Asia Games in Delhi, because there was a huge demand. The organizers even reached us. I said, not able to train people. So we thought of the training nurses and posting them. And none of the nurses were agreed to stay in the ambulance for 24/7. So it's a complete different stream of profession with full commitment. And so glad to hear that things are happening in St. John's and CMC stopgap arrangement for PHMMET. Thank you.
Thank you so much. Yeah. Would anyone like to respond, or if there's any question, and you can unmute yourself and ask. Yes, Neeraj.
So CMC, we have started the pre-hospital ambulance services since last June. So we have been having the paramedic training for almost now 10 years. And our paramedics are quite active. So we as now we started in a small regional area, so around 50 kilometers we cover, and we are liaising with our own hospitals for now, and we are talking with GVK Reddy team. So hoping to extend this slowly towards the other hospitals. But as now we have a good robust system in place where we have a good central command of ambulances, which we only run, and then we decide where hospital patient goes to, and we alert the team earlier itself. So as and when this goes better and better, I feel this is going to be a program which is seeing a good future. So yeah, paramedics do have a very good role. I am a total paramedic supporter. So
thank you. Any participant would like to unmute and share anything that you have, any good practice that you have in your institution, or would like to ask the panelists? So really would like to thank each and every panelist here. Thank you for all this insightful answers and your presentations. And as we come close to today's webinar, I'd like to summarize a few key takeaways. I think risk assessment is not one-time activity, but an ongoing process requiring regular updates. The continuity planning must prioritize both critical services and staff well-being. The climate change considerations should be integrated into all disaster planning. And practical implementation requires customization to your facility's specific context. So we can't just take the tool and use it. We also need to see how to customize it to our own settings. So I want to sincerely thank all our distinguished speakers for sharing their expertise and insights today. So we will have future series of this, and maybe somewhere in June, we'll look at how to manage risk and how to use those different tools. We're still in the planning stage, and this is a series. So slowly we'll unravel, unwrap how do we how do we prepare ourselves for responding to disasters. So if you have not registered, if you can register, the link I have shared, and you can that ways we will have your details so that you can receive updates of our future webinar series and of this series. And so thank you all for your active participation and commitment to building more resilient healthcare system. So with this, I would like to conclude formally this webinar for today.